Thank you for answering the pretest. I am Dr. Edna V. Gonzaga, a developmental and behavioral pediatrician. Welcome to Just the Way You Are, an online CPD on autism spectrum disorders. By the end of this talk, we hope that my fellow pediatricians will be able to detect the red flags of autism in a child based on proper screening and based on DSM-5 definition. And we also hope that we will be able to properly refer a child with probable autism to a specialist for a more closely monitored management. So children with autism spectrum disorders are not only considered special, they have their uniqueness, which we as pediatricians must consider and study. Hence, we came up with the title, Just the Way You Are, if we may borrow a Bruno Mars song. I decided to add a few important definition of terms. Number one is growth. Holt defines it as an increase in physical dimensions such as length and weight. So this is something that is quantifiable, like we can easily take the weight and the height of a child. Then we can have a concrete idea of where he or she is growing. When we talk about development, on the other hand, we do not just include the length and weight. We take into consideration the acquisition of new skills and more advanced or sophisticated responses and behavior, as well as an increase in understanding. Now, these two terms are two important aspects of what we study in developmental and behavioral pediatrics, which is considered as a relatively young pediatric subspecialization. We particularly handle typically developing children as well as those with developmental and behavioral disorders, even those who are at risk, including their families. Okay. Let's just have a review of the different causes of developmental disabilities. First is the premature birth. So as we know, this predisposes a child to a global developmental delay. Same with congenital infections, in addition to different physical deformities that could affect motor development. Even mothers who take drugs and alcohol can predispose to developmental disabilities. Poisoning and traumatic brain injury are also included in the etiologies. And finally, the presence of chromosomal abnormality, which is actually a common cause of developmental disabilities, many of which are undetected or undiagnosed. What are now the examples of developmental disabilities? Number one would be cerebral palsy, which is a disorder of movement and posture, usually associated with prematurity and difficult or complicated delivery. Number two is mental retardation or intellectual disability, which can be hereditary. However, 70% of the time, this has no specific cause. Another is dysmorphology, such as the very common Down syndrome. Many of these children present with global developmental delay. And the last two examples are, we can say, the most talked about today: attention deficit hyperactivity disorder or ADHD, and of course our main topic, autism. We will now concentrate on autism. I'm sure you have heard and read a lot about autism. So what is it? It is actually from a Greek word autos, which means self. We often hear the phrase may sariling mundo. So it is actually a chronic neurodevelopmental and behavioral disorder, usually diagnosed before 24 to 30 months. But the symptoms have already been there even during infancy. It's a very common developmental disorder, and more cases are being identified in the last 5 to 10 years. It could probably be due to increased awareness of the said condition, but we have yet to come with a prevalence rate in our own local setting. It is actually composed of many symptoms in language and social skills, thus a cluster of symptoms. I came across this timeline in the history of autism, dating back from 1908, when individuals with autism were initially considered as a type of schizophrenia. About decades later, a German doctor named Dr. Leo Kanner defined the symptoms he saw in his patients as early infantile autism. In the 1980s, autistic disorder was included in the Diagnostic Manual of Mental Disorders and later included Asperger's syndrome, considering it as a type of high-functioning autism. In 2009, the Centers for Disease Control and Prevention estimated a case of autism in 110 pregnancies. And finally, in the fifth and latest edition of the Diagnostic Manual for Mental Disorders, all subcategories of autism was included in one more general term known as ASD or Autism Spectrum Disorders. So according to DSM-5, the two basic features of ASD are number one, the presence of a deficiency in social communication and interaction, and number two is the presence of restricted repetitive behavior. I will try to expand a little bit on the two features. I will try to give some examples by looking back on the relevant developmental milestones and then zeroing on the red flags to bring us into early detection. So when we say deficiency in social communication, we observe in the child limitations in using language to communicate well. It can range from being totally nonverbal to a child who produces words but cannot use these words to communicate. He or she has difficulty sharing his or her feelings and emotions and needs. Now let us review the milestones in speech and language among preschoolers. For a 2-year-old child, for example, we expect the utterances of 2 to 3 word sentences like, I like this, or hold me, mommy, or sama ako, mommy. He or she should be able to inquire about objects, can imitate parents or siblings, and he must be able to give his or her name and can already verbalize his wants and how or she feels. Like, nakakapagsumbong na siya ng malinaw. By 3 years, the vocabulary increases to 3 to 5 word sentences. He or she can ask questions and recite rhymes. They have now the knowledge of using me, you, or pronouns and can his first and last name. At 4, the vocabulary has expanded already with good grammar. They can already use past tense of verbs and are capable of asking why and how questions. What then are the red flags for ASD in terms of language and communication? So all of the milestones we have presented earlier are significantly delayed or have barely developed. Like you have a 2-year-old who can't even utter mama and papa, who could only repeat syllables as in babbling like ta ta ta, da da da. And he has limited expression of needs, would use hand leading, or can barely use pointing. to express his needs and wants. How about the red flags for ASD in terms of social development? So for these children, they have limited eye contact. They may look at you, but for just a few seconds without any intention to communicate. They also have lack of initiating play. They basically dwell on parallel play, not interactive play. They also have no interest in peers. They would usually prefer to play alone. And they have limited empathy. They could not identify with the feelings of others. Now we go to the second feature of ASD according to DSM-5. So when we say restricted repetitive behavior, these are not limited to gestures such as hand flapping. We may observe repetitive running around the room, walking to and fro, constantly rotating objects, and there are a lot more, but the key word is the repetitive behavior. They have also rigid needs for rules and routines and have obsession, like they find it hard to adjust when they can't have their favorite toy or object. So again, the atypical behaviors include preoccupation with interests with their favorite toys or objects or activity. The sensory-oriented play, this is where their uniqueness in terms of how they smell, how they feel, or how they taste food comes in. And then they also have fixed routines or rituals. Again, they find it hard to adjust. That's why we often hear the word they have we often find the observation that they have poor frustration tolerance. And they have insistence on sameness. So kahit yung daan na dinadaanan, the road that they usually pass going to the school or the therapy center, they would insist on that same road. So pag naiba yon, marami ng pakiusapan o marami ng pwedeng maging cause ng tantrums. So, what can we do as pediatricians, knowing that we cannot all diagnose ASD because we lack the training? So the key is to detect the early signs, so we will not be late in managing the patient. So we have this, we call the developmental surveillance, or basically just a monitoring. This is the information we use this are from the parents themselves, from their stories, from their concerns. So that this would include the developmental milestones of the child and the mere observation of the child's behavior and development. So the other aspect is developmental screening, which is actually the use of a validated screening tool to identify the children who are likely to have a developmental delay, so those children at risk. And when these two have been done, the final step would be to refer the child for a developmental assessment, which is actually a formal testing of a child's development skills using a standardized assessment tool. So one example would be the Griffith's Mental Development Scales and the ADOS for older children who we need to assess. So when do we screen? The American Academy of Pediatric Guidelines recommend screening at age 9, 18, 24, or 30 months. But whenever we have concerns, there's no such recommended time. Whenever we feel like referring a patient, especially if the parents are very much concerned, then we can always do screening. So just to give you a rundown of the screening tools, we have the Ages and Stages questionnaire, the communication and symbolic behavior scales, the Parents Evaluation of Developmental Status or PEDS, and the Modified Checklist for Autism in Toddlers or MCHAT, and the screening tools for autism in toddlers and young children. Now, I would just like to point out that two of these screening tools are the Parents Evaluation and Developmental Status or PEDS and the Modified Checklist for Autism in Toddlers or MCHAT. We at the Philippine Society for Developmental and Behavioral Pediatrics conduct training or workshop to certify users. So this would be very useful for pediatricians, even the residents. We also conduct this training among residents. Now we go to the management of ASD. So this is just a rundown of the general flow of how to manage ASD for our general pediatricians out there. So we must remember that there is no cure. However, there are palliative intervention programs. So this is to take care of the possible limitations that can develop if the child is not managed properly. So the number one on the line is behavior modification or management, and then we also have the language therapy and the psychopharmacology. So when we say behavior management, this would include the applied behavioral analysis or ABA, we call it ABA or ABA, then the occupational therapy. Included also in the occupational therapy are the sensory integration programs. We also integrate that in the occupational therapy. And then there are also communication approaches like the PECS, the Picture Exchange Communication System, wherein the child would use the picture to denote the action that he is supposed to do. And for the speech and language therapy, of course, these are conducted by the speech pathologists. And this is actually to augment any form of communication that is already present in the child, or kung minsan walang-wala talaga, they start up having not much verbal output, but through speech and language therapy they really improve. So again, these are not curative, they just help maximize the language potentials of the child. So in our setting, psychopharmacology is not very popular. Siguro na sa kultura natin mga Pilipino, lagi tayong takot gumamit ng mga medicines. But these are medicines that can help manage related symptoms like extreme hyperactivity, restlessness, sleep disturbances. So this can be range from stimulants, tranquilizers, anxiolytics, or even antidepressants. We also include the provision of special education for those children who, after behavioral management, have improved in terms of behavior, can qualify for education. But this would be an individualized educational plan suited for the child's development. And then there are also dietary approaches, but many do not have scientific support yet. Same with the complementary and alternative treatments, or CAM. There are special diets, chelation, but these are all still under study. So in the management of autism spectrum disorders, we must remember that ASD symptoms are brain-based. No cure has not been discovered yet, but we can prevent cognitive, language, and behavioral deterioration. And this will be possible through early detection and intervention. So we must remember that children with autism spectrum disorders have their own specialness and uniqueness. So again, we go back to Bruno Mars' song, "Because You're Amazing, Just the Way You Are." Thank you for your utmost focus and attention. Please answer the post test. All for the Filipino child.